Welcome, everybody. Welcome to another episode of PEM Rules, the Pediatric Emergency Medicine Podcast. I'm your host, Yaron Ivan, as usual. And today, some more important clinical care tips that hopefully will help you take care of your patients. Rule number 203. Be kind to the radiologist. So this is something I feel very strongly about. It's really my attempt to help other physicians help me. Let's be honest, in the United States, 2024, we physicians, emergency clinicians, heavily rely on the radiologist. So as a physician who's now practicing pediatric emergency medicine for 7 or 8 years as an attending, I certainly feel qualified to look at x-rays. When the child doesn't really have concerning signs and symptoms for pneumonia and the x-ray looks negative to me, I don't bother necessarily wait for the radiologist for something that I think is pretty simple. I send them home with good anticipatory guidance, etc. The same for a fracture. If I don't think there's a fracture, my concern is pretty low. X-ray to me looks negative, something simple like radius and ulna, etc. I don't wait for the radiologist, I just send the patient home. However, let's be honest. With the radiologist, anything beyond X-rays, certainly MRIs and CT, we heavily rely on the radiologist interpretations. So if I think the child has appendicitis, the CBC looks concerning, the exam is concerning, etc., I end up ordering a CT. If the CT is negative, as far as I'm concerned, the child does not have appendicitis. Another example, in a child with a head injury that I'm somewhat concerned has a fracture or a bleed, I certainly take a second to look at the CT myself, but if the CT is negative, I don't really question the radiologist. I don't necessarily call them to make sure. I just cannot take it at face value. Usually they mention something, no skull fracture, no intracranial hemorrhage, etc. And I honestly never really doubt it. So again, think about the reality of the situation in the United States in 2024, when this episode is recorded. We don't really doubt the radiologist, and we heavily rely on them to make the diagnosis or rule out the diagnosis. And that is exactly why I try to give them as much clinical information and description when I order the test. So, for example, in a child with abdominal pain, I will take the second and a half to give them a good semi-short HPI and why am I concerned about appendicitis in this child with abdominal pain. In a child with a fracture, I will tell them exactly where my point tenderness is on exam so they can kind of focus their examination and their interpretation of that bone, that extremity, etc. I think it's very important to give the radiologist as much clinical information in order to make their judgment and their interpretation most valuable. I can imagine how difficult it is to read through so many CTs, MRIs, X-ray without having good and sufficient clinical information. I think it's important to remember that although radiologists are not clinicians, they don't treat patients, they certainly help us a lot with making the diagnosis or ruling it out. And I can't imagine sitting in the dark room looking through all those X-rays and CTs and MRI without having good amount of clinical information to put together with the pictures you're seeing in front of you. It only takes a second and a half to elaborate a little bit about your HPI and physical exam and your concern with that CT, MRI, etc. So when ordering abdominal CT due to concern of appendicitis after the ultrasound wasn't particularly helpful, etc., saying something like right lower quadrant tenderness for 3 days, inability to jump with leukocytosis, concern for appendicitis, I think that really helped the radiologist a lot. Now he or she know exactly what to look for, what the HPI is, what the concern is, the physical exam findings, etc., and what exactly I need from them. Abdominal CT is just a simple example, but many times the concern is a lot more complicated. For example, brain MRI on a child with focal symptoms, etc. So again, make the radiologist's lives easy by giving them a good description of the HPI, maybe the exam, and the specific concern. What exactly is the question you're asking them? Make it a little easier for them to pinpoint their interpretation and their focus of the exam. It only takes a second and a half to write some kind of sentence or some kind of description in the order that you put in for the CT, MRI, ultrasound, or whatever that is. So remember rule number 203. Be kind to the radiologist. They bear a lot of responsibility and are there to help you out. Help them out by giving them a good description. Rule number 204. Be aware of false negative. So, this is just a very important rule to keep in mind. I think parents, patients, and clinicians truly rely on tests, but it is very important to understand that all tests have limitations, and whatever test it is that you're using, you better be aware of those limitations. I think patients today really rely on negative tests. If the chest x ray is negative, they go home knowing there's no pneumonia. If the CT of the abdomen is negative, they go home thinking there's no appendicitis. But all tests have some kind of limitations, and knowing those limitations is very important. Just a few examples that come to mind. For testicular torsion, the literature cites sensitivities of about 78.6 to 100% and specificities of 76.9 to 100% with a negative predictive value that is very high. Again, not 100%. So just because the testicular ultrasound is negative doesn't mean the patient doesn't actually have testicular torsion. Think about your history, think about your physical exam, and remember, all tests have some limitations. I think another classic example is the rapid strep test. Number one, that test really depends on how cooperative the patient is and how experienced that nurse is obtaining the sample. It has a lot of variability depending on the technique and how cooperative the patient was, etc. Secondly, while this test is very specific, its sensitivity ranges from 60 to 90%. So just because the rapid strep was negative today doesn't mean the patient doesn't have strep throat. Very important piece of information to relay to the parents, very important to keep in mind. If your concern is very high, maybe give them rescue prescription for antibiotics or make sure they follow up very closely. But just remember, rapid strep does not rule out strep pharyngitis 100%, unfortunately. In the same way, a urine analysis is not the end-all be-all to rule out UTI. In routine practice, clinicians can perform urine dipstick test, which confirms the diagnosis of urinary tract infection with sensitivity that is as low as 45%. Remember, if the teenager in front of you has frequency, urgency, dysuria, and everything kind of fits, just because the test is negative today doesn't mean he or she do not have a UTI. If that newborn or toddler in front of you has high fever and vomiting, a normal urine analysis, unfortunately, does not rule out UTI. Check out the UTI calculator, etc. Always look at the clinical picture and don't obtain the test if you don't really need it. Getting unnecessary tests is like picking your nose in public. What are you going to do if you find something? Think about your history, think about your physical exam, and think about the fact that if the test is negative, unfortunately, it doesn't rule out the disease always. Far from it. Rule number 205. One view is no view. This is a very, very good rule to remember with regards to chest x-ray, for example, for pneumonia. I can't tell you how many times the AP x-ray to me looks totally normal, the clinical exam is for the most part reassuring, but when you look at the lateral chest x-ray, you actually see a very clear pneumonia, which kind of fits with the physical exam and everything else. Chest x-ray that is just an AP view really doesn't help you a whole lot. Always remember to obtain a 2-view chest x-ray if you really want to rule out pneumonia. If you're looking for something like pneumothorax, sure, AP may be sufficient. Another good example for this rule is the simple extremity x-ray. I can't tell you how many times the PA view does not look like much of a fracture, no significant angulation or displacement, but when looking from the lateral view, things look a lot worse. Especially with the extremity fractures, very, very important to always get a 2-view. 1 view is no view. It's almost like getting a CBC looking at anemia without knowing the MCV. The differential diagnosis changes significantly if it's a microcytic or macrocytic anemia. Always look at a CBC and hemoglobin with the MCV. Kind of narrow your differential diagnosis and get the full picture. So remember, with regards to x-ray, single view or one view is really no view at all. Always get 2, 3, or 4 views or as many as you need to make sure the fracture is not significantly egulated, to make sure there's no pneumonia, etc. And that is it for today, guys. Thank you very much for listening. Let's briefly review what we learned. Rule number 203: be kind to the radiologist. Remember, there's a radiologist sitting somewhere, not seeing your patients, not having a lot of clinical information. Giving them a good clinical description and asking them a specific question of what you're looking for can go a long way. It will help them help you. And let's be honest, we rely on radiologists a lot. Rule number 204: be aware of false negatives. Whatever test it is that you're using, be aware of its limitations, sensitivity, specificity, etc. And make sure the parents are aware. Just because the test is negative today doesn't mean that we rule out the diagnosis 100%. There's still good anticipatory guidance to give. Rule number 205: one view is no view. When looking for pneumonia, AP chest x ray doesn't go a whole lot of ways without getting a lateral also. When looking for a fracture, never rely on a single AP view. Get the lateral, get the oblique, make sure the displacement is not significant, etc. Also, if you're about to reduce the fracture, knowing where the displacement is goes a very long way. So remember, one view is no view. And that is it for today. I hope you enjoy PEM rules and continue to support the podcast. Please check out the Facebook page, check out my articles on EP Monthly, and continue to write back if there's anything you want to talk about, anything you want to hear about. I'm always happy to hear from you guys. The following outro is one of the best acoustic solos I've ever heard. This song was by a band called Mr. Big. I think they were a one-hit wonder back in the 90s. This is called To Be With You. Hope you like it. Have a great day.